Shall I share my screen?
I like to welcome everyone, sir. Dhiraj,
Yes, sir. Noted, sir.
should I welcome?
Sir, we are live. Dr. Suresh Pillai will be starting with his first talk.
Yeah, I am.
Yes.
Yeah.
So, Dr. Suresh.
Am I visible?
Yeah.
Good evening, all of you. Am I audible? Hello?
Yes, you are audible.
Yeah.
All clear.
The cervical disc disease is a common problem in our day-to-day practice. The objective of this management of cervical disc problem is first is resolution of pain, then improvement in the functional limitation, and reversing or improving the neurological deficit which has already occurred, and prevent further deterioration of neurological deficit. Actually, it is rare for a patient to have or progress to myelopathy with a disc disease, and in rare occasions it do. So we can try an extended period of conservative treatment, and more than 75% of patients with cervical disc disease get better with conservative measures. The problem is there is no exact or no randomized controlled trial comparing the conservative measures with the surgical treatment of disc disease. Those patients which are absolutely indicated for surgery, they are not compared for or randomized for conservative measures. So most of the patients with cervical disc disease get better with conservative measures, except in rare cases like this. Here, the patient went on to have quadriplegia with the disc prolapse. Mostly pain is either because of compressive element which causes conduction defect in the nerves or affecting the vascularity of the nerve, or it can be due to mechanical causes and chemical causes because of the inflammatory pain mediators that do upregulate the sodium channels or sensitize the person for increased perception of pain. And 75%, as I mentioned, 75% of patients with the conservative cervical radiculopathy get better with conservative measures. We do different methods of treatment, either absolute bed rest, cervical traction, collar, muscle relaxant, chiropractic, physical therapy. All these methods are practiced, and there is no definite rule or definite criteria which all patients get better with traction, medicine, or other measures. We can try all this, and there is no rule that this should be followed for so many days, for so many hours for the patient to get better. But still, all these are tried with variable results. Or there are n number of pharmaceutical agents, and all the specialties from modern medicine, allopathy, Ayurveda, and all the branches are practicing or treating cervical and lumbar disc disease. And we can try soft collar to immobilize the cervical spine for about 20% of its movement. And traction is controversial. There is low level of evidence to support that traction is more effective than placebo in patients with cervical radiculopathy. And in acute setting, we don't advise so much of exercise. Once the pain settles, we can ask the patient to do different exercise to strengthen the neck muscles and adjusting the posture. And another method is cervical epidural steroids, and 50 to 60% of patients get relief after epidural injection. And in some studies, they do more harm than good. And it is shown that by 6 months, there is no difference between the two groups. And epidural steroids, and there is no way to determine which patient will benefit from cervical epidural steroids. And some of them get better, some of them not. And the risk involved are neurological deficit, epidural hematoma, thinning out of the dura, vascular infarct, arachnoiditis, and so on. And it is recommended, the recommendation is that it should be used with caution pending further study. So in conclusion, conservative measures are adopted for more than 75% of patients with cervical radiculopathy with good results. And there is no randomized controlled trial available comparing the conservative and surgical treatment for cervical disc disease. And there is no definite idea how long the conservative measures are to be followed. And many methods of conservative treatments are available. So you have to individualize the patient and treat them accordingly. Thank you.
Thank you, Dr. Pillai. That was a nice, concise talk. Any questions for Dr. Pillai? Okay, so I will take the opportunity to ask you a question. So what's in your routine practice? How you decide a conservative treatment as per the duration of symptoms, the clinical presentation, and as per the size of the disc? So what are your criteria?
Unless the patient is having myelopathy, I try a trial of conservative treatment with anti-inflammatories, pain relieving, other pharmaceutical agents, soft collar, traction in some cases. Some cases, if you apply traction, they may have an increase in pain. Okay. But we can try all these measures. And if the patient doesn't improve, or if the patient is unable to sleep, and if the deficit is increasing more, then we can try for give the option of surgical treatment.
Okay. Any role of oral steroids in conservative management?
Oral steroids, usually I don't give. Some people use oral steroids, just like epidural steroids, can be tried as an anti-inflammatory agent.
Right. Okay. Thank you, Dr. Pillai. So since there are no questions from our faculties, so we'll move on to our next talk by Dr. Ranjith Unnikrishnan. So Dr. Ranjith Unnikrishnan is a senior spine surgeon from Kerala, and he'll be speaking on spinal versus extraspinal causes of radiating pain. So this is very extremely important talk, which will help us in differentiating the radiating pain, which most of us thought are from spine. So over to Dr. Ranjith.
Thank you, Dhiraj, and thank you, Best Zone, and thank you, Dr. Ajit and team. Dhiraj, can you allow me to share my screen?
Dr. Pillai, unshare your screen. OrthoTV.
Yes, sir.
Please allow Dr. Unnikrishnan to share the screen.
Okay, sir.
Can you see my screen?
Yes, clear.
So basically, thank you, Dhiraj. We'll hit right away. And thanks, Vishal, for the introduction. So basically, what we're talking is about sciatica mimicus.
Yeah.
So these were 4 patients who came to us with back pain and leg pain. Female, male of young to old age group, and all came with back pain and leg pain, and all had different causes. So the onus lies on us to understand how to know that it is because of extraspinal cause. Classically, we have been taught this way that radiculopathy is a pain which is radiating down the leg in a dermatomal distribution. And we were always taught as residents that there are only A, B, C, D cause of this. Accessory, the visceral muscle, osteophyte, that is bone, C, cancer, D, disc. By far, we focus a lot on the D part, that is a disc, as a cause of radiculopathy. Now, what are the common cause of error in diagnosis? Because we might have a very typical history like this patient who the MRI looks like this with the classical symptoms, typical exam findings, and we have typical imaging features, and we think it is radiculopathy. The first thing is, don't ever inherit a diagnosis. Always re-evaluate the patient, because there might be something atypical in the patient's history, what is causing this pain. And always look at the timeline of symptoms. So I'll take a couple of cases in which I got caught. So this was an elderly female who have been seen for a long time with back pain, leg pain. And she had this MRI picture, she was having claudication, and at some point of time, we had discussed that we need surgery at some point of time. She told me, doctor, now I cannot hold anymore. I got severe buttock pain, leg pain, let's go ahead with surgery. So looking at this MRI, okay, we admitted the patient because we knew the patient a long time. And it is customary for us, we always re-examine or re-image the patient. And on examination, we found that this was the cause of leg pain, what she had, which had developed over the 3 years, which I was seeing her. So, which my joint guy went there, put in a hip, and she became totally pain-free. So what are the learning point here? Do not assume the diagnosis, even if you know the patient. Repeat detailed examination on every visit and do not use a borrowed diagnosis. And whenever in doubt, always repeat an imaging. So this interesting paper, which looked at non-discogenic cause of radiculopathy in 104 patients, you can see that a vast majority of them is because of peripheral neuropathy. Next, due to vascular disorders. Next, due to pelvic and hip pathology or extraspinal tumor causing radiculopathy, plexopathy, infections, and entrapment neuropathy. This is very much, I'm sure all of us have the same distribution in our practice when we see it. And most common cause of radiculopathy are herniated disc, but 17% have non-discogenic cause of radiculopathy. That's roughly one-fifth of your patients. So we have to keep in mind when we look at them. Another interesting paper published last year, which 17, which looked at common diseases mimicking lumbar radiculopathy. The most common cause was myofascial pain and entrapment neuropathy. I'm sure all of us see this in unison or along with other diagnosis. Next is piriformis syndrome, where we have the classical we get a radicular pattern pain, and look at the anterolateral thigh numbness, and that's how you pick it up. And cranial nerve entrapment, which happens in around 1 to 15% patients, and myofascial pain at the suprapatellar region. So all these causes can cause entrapment neuropathy, and they present very much like radiculopathy, which we have to differentiate. Another patient was a female, 35-year-old. This was the MRI. She was having back pain, leg pain, and she was advised surgery for disc collapse, and she was having an MRI. So when we saw to it, we are not very sure that why should that old MRI, which is a black disc of radiculopathy. We repeated the image previous day, and we could find that the cause was a facetal cyst. So we endoscopically went and decompressed, and the patient got better. So what are the learning point? Even if you know the history, review the history, look at the timeline, understand and respect the natural history. If it doesn't fall into the classical pattern, review the imaging and in the clinical context. Another patient, a 62-year-old male who had back pain, leg pain, a degenerative, long time known to us, was having back pain, leg pain, was treated non-surgically, and at some point of time he was told that he will need surgery. So she came to us with this. He told, doctor, I cannot hold anymore. I got difficulty in walking. Now I cannot hold anymore. So on repeat examination, we found that he had upper limb weakness. This is the MRI done previous day than the planned so-called surgical procedure. We saw he had upper limb weakness, and we took an opinion and did a repeat imaging of the dorsal spine, and he had ALS. He had ALS, which got better with medical management. So again, respect the history, even if it is very, 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 very classical. This is another patient who had long-standing back pain and was having leg pain, and this was the X-ray, and he had an MRI which showed a black disc, and he came to us with this where he was advised surgery. We repeat the image, and we found that there was a higher up cause. This was a renal cell carcinoma metastasis. Again, repeat the imaging if there's an acute change in clinical symptoms. Plain X-ray history always seen prior to the MRI. And if you have inappropriate or poor quality MRI, please do repeat it. Another very classical thing, back pain, leg pain, back pain of long-standing duration, was advised surgery for whatever reason for the pain. And when we took a history before our last consult, he told about bladder symptoms. Went ahead, we repeated the MRI, we saw a large tumor in the L2, took it off, it was meningioma, all his symptoms recovered. Again, remember that whenever you have this kind of picture, please re-image. Another lady, very common diagnosis, diabetic elderly having back pain for long-standing duration, paresthesias, was told that it is because of diabetes, and she told that she has got some bladder symptoms which happened of around 2 months duration, which is thought to be due to diabetes. So we were not very sure. We did a PR and found a patulous anus, got a repeat MRI and CT done, and that was a tumor from the NF from the root, which was eroding into the bone, and that was clotting of bladder symptoms. Again, learning points. Be aware of overlap syndromes. Just because you have diabetes and long-standing back pain doesn't mean that that patient is the problems because of that, please ask for this recent change in bowel habits and always have a very low threshold. Patient who was having back pain of long time duration and developed some leg pain and was told that, well, now you cannot, she told she cannot live anymore with the pain. She was advised surgery. So we could not explain why she's getting back pain and leg pain with this MRI. We went ahead, repeated the image, and we found that she had a leiomyoma, a tumor from the uterus, which is causing plexopathy. This was the cause for her leg pain. So when they went to gynecologist, they took off the tumor and that resolved her leg pain. Again, what we learned, always think laterally, look at extraspinal cause of radiculopathy. If it is, even though it is not common, do look into it. And if your picture is not matching, look into the retroperitoneum, look into the pelvis, and have a strong suspicion. Another very interesting article, extraspinal cause of sciatica, which looked at the incidences of leg pain, back pain, not due to radiculopathy. And the most common causes were piriformis syndrome, spondyloarthropathy, myofascial syndromes, cluneal nerve entrapment, extrapelvic entrapment neuropathy, like what we saw in one of the last patients, and benign tumors of the sciatic nerve, hip arthritis, and even catamenal sciatica, where there is ectopic endometrial tissue. The patient gets leg pain during her periods. In this, you treat it with medical management and it gets better. And post-injection sciatica, which today is a rarity for most of us. So to conclude, if classical symptoms of sciatica, think ABCD. Please do not entertain a borrowed diagnosis, even if it is done by your senior or your professor. Try to consider interval disc prolapse as a cause of radiculopathy as a diagnosis of exclusion, even with obvious imaging support. Review the clinical history, exam, and imaging prior to treatment, again if needed. When in doubt, do not hasten a diagnosis and advise surgery. We all practice primary non-nocere. Thank you. Any questions?
Thank you, Ranjit. That was excellent cases from your collection. So, any questions from Dr. Ranjit?
So, Dhiraj, I have one question. So, Ranjit, how many patients do you see who are actually having sacroiliitis? Because what I have noticed in my practice that sacroiliitis, we are never able to elicit those classical signs. You know, like 3 out of those 5 should be positive. So I'm never able to kind of, elicit those signs whenever I suspect sacroiliitis. So how do you rule out a sacroiliitis? And how do you approach
that's a very good question, Amit, because most of the times the so-called clinical sacroiliitis is not sacroiliitis. It is due to myofascial pain or pain coming from the lumbosacral joint. The thing happens, the patient comes with an MRI and the MRI reports sacroiliitis. It is documented that 30% times you will get asymptomatic sacroiliitis on MRIs. It has got no clinical significance. So for me, it makes more sense if it is unilateral, when I can elicit all the signs and the X-ray, MRI, and CT shows a destruction. That is when I think in terms of sacroiliac pain. I am a firm non-believer of the SI joint being a cause of the so-called radiculopathy back pain. I don't inject any SI joint, did all those earlier, but I don't think that is a factor in unition unless it is because of infection like tuberculosis or spondyloarthropathies.
And many of these nerves you mentioned in differential that which can be a cause of radiculopathy. How do you identify them? Is it EMG and you will diagnose them?
Yeah. So what you do is that when the pattern is not typical, imaging is not supporting. For me, it's always a retrograde. There is leg pain, there's no tension signs, but there is paresthesia. Then since I read this and knew this, I go and see the dermatomal distribution and try to see if I see a patch, I send to the neurologist. They do an NCV. I've got a guy who's interested in this. So he does the NCV, NCS. He samples the paraspinals and comes to a conclusion that this is it. And we inject it and the patient gets better. We inject the so-called entrapment, the patient gets better. I've never ever had to release a cluneal nerve. I've done occasional piriformis release, which was recalcitrant to all sort of injections, and they got better.
Okay, thank you.
So I will just share one of my DDs. So that was very unusual for me. One patient presented with very sharp shooting leg pain, a middle-aged young guy, and he was having foot weakness. So on the assessment, and he was crying with pain. So foot drop and severe sharpshooting pain down the leg. So on further evaluation, we found out there was a critical limb ischemia. He was not showing any ischemic changes initially, but later on he presented with some, and he was having a disc also in an MRI. Okay, and that was maybe just an incidental finding, and he was having a big thrombosis from popliteal to the ilium, iliac, external iliac, and on further evaluation we found that the pulses was not felt. He was a smoker, and on Doppler and angiography were able to pick up. But this patient initially was very similar to a sharpshooting, to a disc with a foot drop and sharpshooting.
Yeah. Actually, that is the case. Now, when you have overlaps, it's most of the time we might get caught.
Yes.
This kind of, so the overlap is where actually, especially when the patient has been told that, well, this is the cause of pain, and they think that they need surgery or intervention, then they come out to us, and when we try to reevaluate, if you look at the timeline of symptoms, it doesn't fit into the classical pattern. Yes. Right? That's when we suspect that, well, in my practice, I see a lot of these 0.3, 0.5 test MRIs, which is a fog. So you don't think that, you cannot explain it. So when I ask them to repeat an MRI, they're hesitant. So I tell them that, see, I'll operate on you with this and you will not get better. Are you okay with it? Right? And that's when, they might be willing for a repeat imaging, and then we pick up something new.
Right.
That's it. Yeah.
And in our routine teaching, we are only knowing the differential diagnosis as a claudication pain, as a neurogenic claudication, which happens in an atherosclerotic. We have never been taught about all these causes, or most of us don't discuss about all these things.
Exactly. So this, my practice is to always look at IVDP or a disc prolapse as a diagnosis of exclusion. So I try to think that every patient who might see a radiculopathy, the pain is not because of disc. So then when you try to reevaluate, then I see, okay, fine, everything is ruled out, then let the disc be the cause of pain. That's my take at it, Dhiraj.
Right. So we'll call on next speaker. He's already waiting for us. Dr. Naveen Tahsildar. He's a consultant spine surgeon in Spurge Hospital, Bangalore. Over to Dr. Naveen.
Okay, good evening, everyone. Hope you can hear me. Can you hear me?
Yes, clearly.
Yeah. So first of all, I respect each one of you for controlling your urge to jump in front of the TV to watch the cricket match. And at the outside, I thank the West Zone IOA, Dr. Ajit Shinde, and OrthoTV for providing me an opportunity to present some interesting cases. So let me just dive into what all of us as surgeons like with cases. So this 11-year-old boy, low back pain radiating to both lower limbs, left more than right since 25 days. Severity was increasing since last 10 days. He also had a limp and disturbed sleep. History of carrying some heavy weight like a school bag on shoulders. No other significant history. On examination, he had the flexion was painful. SLR was positive on the left side. He had pain on both sides though, and other tests were negative. And this is how the MRI looked. So you can look at the L5S1 there. So there is this disc protruding and pressing on the roots, bilateral S1 roots, very central, a little bit on the left side. The axial sections again. So since it's a webinar, there cannot be much a lot of interaction here. I'll just go quickly through. The diagnosis was a pediatric disc prolapse. The incidence is about 0.5 to 3%. The mechanism of injury mostly is a sports injury or a weightlifting injury. Is there a genetic predisposition? Maybe, but there is no definite evidence for that. And if you look at this situation, it's more of an epiphyseal injury with separation of the cartilaginous epiphysis with the bony fragment sometimes, like a Thurston-Holland fragment, and which is why higher percentage of these patients fail conservative treatment, unlike the adults. So this group of patients do well over long term. They will definitely need a surgery mostly. They don't have a lot of back pain in the future, and only few need fusion due to persistent back pain. Now, this was our patient. So you can see his result. So he did well post surgery. He could his pain was relieved and did quite well, and he's on follow-up and he's consistently doing well. No other issues as of now. Now, I'll go to another interesting case. This one lady, one small girl, again a pediatric, 11 years old girl, low back pain while standing and walking. Her standing time was significantly compromised. Her walking distance was compromised. She had a deformity in the back and she was unable to maintain a standing balance. Along with that, she had radiating pain down the legs, a radicular pain. So on examination, she also had features of NF1. She had a significant coronal and sagittal imbalance. I'm quickly going to put a photograph and clinical picture right away. And she had a forward and left tilting of the spine. She had a right knee in flex posture and tight hamstring. So this is how she looked. So you can see that she had a coronal as well as a sagittal imbalance, and she's finding it hard to stand, to maintain that standing posture. So this is the comparison of her X-ray. Again, you can see that even on the standing and standing lateral and AP X-rays, she has an imbalance. So she had this dysplastic high-grade spondylolisthesis, and you can see there are all features of the NF1, this scalloping of the vertebra, and all other features, osteoporosis. So this is how her MRI looked. She has dural ectasias at all the levels in the lumbar. And this is how she walked. So she had a lot of difficulty walking, maintaining that posture. The challenges here were, so she definitely needed a reduction of the spondylolisthesis to restore a spinopelvic balance, which hopefully should resolve the global spinal imbalance. The osteoporotic bone in NF1, which threatens pedicle screw purchase, as you know that the pedicles are very thin and osteoporotic. Dural ectasias, eroding bone leads to thinner pedicles and changed orientation. And access to L5S1 disc space is further compromised because of dural ectasias. And the tight hamstrings prevent correction of the pelvic tilt. The plan was to basically instrument, reduce the listhesis and do an interbody fusion along with decompression. So post-op course, she was operated uneventful surgery, reduction was achieved, interbody fusion was done. But on day 4, she complained of severe pain on standing. I could see that I don't have the X-ray at this point of time. The screws at L4 were pulling out and L5 screws were partially pulling out. She was taken back to the OT and extension of instrumentation was done to L3 proximally and ilium distally. She was given bed rest with gradual stretching of hamstring in supine position for 3 months. The tight hamstrings were another reason why this could have happened. And of course, I should have gone to L3 and ilium at the outset. Now, retrospectively, when I look at it, probably that would have been the best approach. Started on mobilization from 3rd month onwards. In a sense, she was walking around, but with some restricted mobility. But she recovered very well after that. So this was her post-op picture, the pre and post AP and lateral X-rays, standing X-rays. Again, the pre and post X-rays of the lumbar spine. The reduction was satisfactory and the interbody fusion was going well. So this was a pre and post-op clinical photograph, the lateral picture from both sides. So this is how she was doing well post-op. Now, I'll quickly mark, I'm not going to go through the details of the history. I'm just going to flag some of the interesting things that can happen in all our spine practice. Like Dr. Ranjith Unnikrishnan just, he actually pointed this thing. Now, I'm going to quickly dive right into the heart of this topic, cervical myelopathy in the background of an undiagnosed motor neuron disease. Whenever we have a case of cervical myelopathy, I think most of us should be very careful, before we put our diagnosis, that you do a detailed neurological examination and see if there is something else that, one of the common differential diagnoses of cervical myelopathy is a motor neuron disease. If it's a clear-cut case of a motor neuron disease, I think, you can diagnose it with a nerve conduction and electromyography. But the case that I'm going to show you now is a case which had both of these, both cervical myelopathy and a motor neuron disease. This was the X-ray and the CT doesn't show any signs of OPLL. So you can see that the disc at 6-7 is a 5-6 is a problem. There is clearly a myelopathy at that level, a significant myelopathy. Even on clinical examination, this patient had features of upper motor neuron signs in the lower limb. So we actually went ahead and did nerve conduction study, electromyography, and then realized that she also had motor neuron disease. After very careful deliberation and realizing that her situation had deteriorated very recently, and so it was a stable motor neuron disease which was being threatened by a cervical myelopathy. She underwent a surgery to decompress the spine and stabilize the spine. One of the things that you should always remember is motor neuron disease tends to worsen after any kind of surgery due to probably due to an inflammatory process that is set in by a surgery. So you should actually carefully deliberate with the patients to explain to them that there is a possibility that the motor neuron disease may worsen and a neurological situation may actually worsen. This is one of the criteria that is used for the motor neuron disease. It's the Awaji-Shima criteria. I'm not going to go through the details here. Now, there's another situation that can come up in the same set of these patients, motor neuron disease. I had a few of these patients. This patient had a right S1 radiculopathy, again in the background of a motor neuron disease. There is radiating pain going down the leg. But when you carefully examine these patients, the motor weakness is actually out of proportion to the regular clinical scenario that you see. That with the disc, you don't have a lot of weakness, but these patients tend to have a lot of small muscle weakness. So obviously this patient had a proven motor neuron disease on investigation. But since her radicular pain was the one which was troubling, we went ahead and did a discectomy. So her pain was relieved. But again, we have to put a word of caution to the patient that surgery can actually deteriorate a stable motor neuron disease. Now, coming to another interesting setting that can come in is a Cauda-Equina syndrome, which can present late. So this was one of our patients presenting at 1 month with Cauda-Equina syndrome, established Cauda-Equina syndrome, which was decompressed. The things that you have to remember, this is one of our studies which we did 10 years back. So outcome of late decompression in Cauda-Equina syndrome is actually favorable and not universally poor. You should go ahead and do a decompression, and you can expect a good motor recovery. But the things that usually don't recover that well and which are very unpredictable are the bladder recovery and the perineal numbness, which the patient keeps complaining at every visit. And one of the things that you can always look for is the presence of an anal wing during presentation, which actually is a positive predictor of a good recovery. Now, coming to the last interesting case here, again, this can regularly come up in your OPD. You can see a cervical radiculopathy. You can see this disc pressing on the nerve on the right side. This patient also had a significant weakness in the upper limb. The right side deltoid and the biceps were weak, and the weakness was completely out of proportion to the size of the disc or the pain that there was more weakness than pain. So this is a situation, when you should always think of different diagnoses like a brachial plexopathy. This is commonly called as a Parsonage-Turner syndrome, which is actually a viral plexitis of the brachial plexus. When you have the situation, always get nerve conduction study with a electromyography. So you can always you can come to a diagnosis, and most of these patients get better with steroids. And you should not think about surgery in these patients because surgery will do no good and may actually worsen the situation. To conclude my talk, so this great aphorism about surgeons, sometimes, maybe often, wrong, but never in doubt. So I think sometimes we need to, come down with our think of a lateral diagnosis, have a lateral thinking in your OPD, and probably, help the patient by using your clinical skills and your clinical knowledge rather than your hand or your surgical skills, and help them out, get out of your OPD and see them happy when they come back to you. Thank you very much.
Thank you, Dr. Naveen. Wow, it was wonderful to hear you. So I have a question for you. So can you tell us in brief how to differentiate between this motor neuron disease and this myelopathy or other form of spinal motor deficits?
Yeah, so motor neuron disease usually presents with both upper motor neuron and lower motor neuron signs. That's a classical kind of an MND. So whenever you see a lot of lower motor neuron symptoms in a cervical myelopathy, I think that's one of the flagging things that you clearly look. But of course, there are some other subtypes of motor neuron disease which can have isolated, it's called a primary lateral sclerosis, which can actually, look very similar to cervical myelopathy. So I think it's a good idea to get whenever there is a little bit of discrepancy in the history, how it has been progressing. If it has been progressing very slow, I think you should always get a nerve conduction study and electromyography because there are clear-cut criteria on EMG, NCS to differentiate between motor neuron disease and cervical myelopathy.
Okay, great. I've seen your first case, the spondylolytic listes in a young girl. We usually see crouching and hip and hip flexion in such patient, but I haven't seen any scoliosis and tilt.
Yeah.
So I don't know how you explain this.
Yeah, so I think some of these patients have a rotational element to the listhesis. It's just not the pure translation that is there. So if there is a rotational element to it, the side that it rotates, it almost acts like the torsional force, I think, creates the coronal imbalance.
Okay, great. Any questions for Dr. Naveen?
Yeah, can I ask a question?
Yeah, please.
Yeah, thanks, Dr. Naveen, for excellent presentation. There is one more thing I would like to add that, like we have discussed about M&D, but the cervical radiculopathy can mimic in case of Pancoast tumor as well, which is like the very, very common cause, like patient who is having chronic smoking habit and other things, and patient typically present with typical cervical radiculopathy with clinical and radiological imaging matching. And then you find out sometimes incidentally you find out on MRI image that there is a small tumor existing in the lung. So this is just the thing I want to highlight.
Yeah, absolutely. Thank you, Hitesh.
Great. So we'll call our next speaker, Dr. Ayush Sharma. He is here and he has already sent a recorded talk. So I will share his talk. Can see?
Yeah, there can see.
Yeah. So I'm playing his talk. Yeah.
Thank you for this opportunity. I'm Dr. Ayush Sharma, and I will be talking on MRI in cervical and lumbar disc herniations. So yesterday I wanted to visit this beautiful Japanese town. It is called Kurosaki. And this is what I did first. I went to the Google, did the search on the Google map. This map tells me how to go, what is the distance. It also has a lot of options which tells me the terrain of that area. It tells me the traffic which I'm likely to encounter, the distance or the time which I will take to reach there. So finally, I was able to visit this beautiful town, and I used all the inputs I got from the Google map. Enjoyed my Saturday evening in this beautiful Japanese town. Similarly, this patient, 31 male, presented with radiculopathy, and we got MRI done. An MRI showed a C5, C6 disc on the right side. It not only told us a diagnosis, it told us that there is a single pathology. Only a right side disc is the culprit, which is causing the radiculopathy due to compression of the disc. So as you can see, we planned a endoscopic discectomy. The annulus was cut. The disc fragment, which is the pathology, was removed, and this is the disc. As you can see, it is being removed, and the decompression of the root was confirmed. As you can see here, this is the root. If you use the endoscope, this is how a root looks like after decompression. Not only this, we also got a post-op MRI to see if we have done a decent job. So MRI for disc herniation is not just a tool. It allows you not only to diagnose the pathology, but also allows you to plan your surgery, to predict your surgery. It has lots of advantages, like it gives you multi-modal imaging at a fraction of radiation. This is a 55-year female. She presented with neurological claudication, and we got a lumbar MRI done, and we saw that she had multi-level disc pathology. But when we examined her, we also saw that one of the grip strength was weak, and that is the time we got a screening MRI done. And this is what we realized, that we have missed out on a C3, C4 pathology. So it is not only important when you are ordering MRI for a disc pathology to order a regional MRI, but it's very, very important to get a screening done. These are the two most popular imaging sequences which we do, which is T1 and T2 weighted images. They're not only important, but they are complementary to each other. As a general rule, T2 is used to look at the pathology, and we use T1 to look at the anatomy. And these, you can see two images of T2 weighted images for disc herniation after a pre and post-op images after cervical and lumbar spine surgeries. We also use contrast to look at the tumors, infections, but even for this, contrast MRI can be very, very important, especially when it comes to recurrent disc herniation, because if you have a recurrent disc herniation, there is already the anatomy is distorted, there's already a fibrosis, and a contrast can tell you better if there is a reherniation. There's some spatial sequencing just to enumerate. You have a stir image with this short tau inverse and recovery imaging, which is very, very sensitive compared to other images and can be used sometimes. And there's a lot of interest today in DTI imaging, which is diffuse tensor imaging, especially when it comes to cases of disc herniation in cervical spine leading to cervical myelopathy. This is just to enumerate the various sequencing that can be used to diagnose the lumbar and cervical disc, but I'm not a radiologist, so I'll keep my talk to the relevant pathology and how to diagnose them. When you look at a cervical or lumbar disc degeneration on T1, T2 weighted image, you can see a lot of information they give you. Even the two sequencing can tell you what is the height of this, whatever pathology you're expecting, what is the site of the herniation, how to go about it. And similarly, this is a sequestered disc on T1, T2 weighted images. Again, only these two basic images can be good enough to diagnose the pathology. But not only that, MRI can be a very good tool to detect some abnormal pathologies of disc herniation as well. This our paper which was we published in 2018, and we tried to diagnose, we had a case series of interdural disc. So if you see this images, this is something called a crumbled disc sign, which you can get on a T2 weighted MRI. And when you see this crumbled disc sign, you should suspect a interdural disc. There are times when this can not only migrate into the epidural space, but it can migrate inside the dura. And even a MRI could be a good tool to diagnose these images. Similarly, sometimes MRI can be used to predict post-operative outcome. This is another paper from which we published, which looks at the post-operative outcome, the role of MRI in predicting post-operative outcome, especially when it comes to cervical myelopathy due to cervical disc degeneration. It's not only important to order MRI, it's very, very important to go and screen all the sequences to look at all the images yourself. If you look at this image, it looks the MRI of a lumbar spine, which looks absolutely normal. But actually, this is what this MRI is doing to you, because if you don't look at all the images, you're likely to miss out on important extraforaminal disc. So this is very, very important to not only just read at the report, but to go through all and every image and cut if you don't want to miss out on some very important findings. So for me, MRI in cervical and lumbar spine is like a poor surgeon navigation. It not only allows you to diagnose the pathology, it also allows you to predict the surgery. It allows you to navigate your surgery. It allows you to know the outcome of the surgery. This talk is not from a radiologist. This is talk from a surgeon. And most of this, which I try to cover, are my mistakes and my take on what a surgeon should not miss out while ordering a lumbar or a cervical MRI for disc pathology. Thank you so much. Thank you for the opportunity.
Wonderful. So that's
Yeah,
a
Neeraj,
nice talk by Ayush, up to the point. Any questions for Dr. Ayush from our faculties?
Dhiraj, Amit here.
Yeah.
So
Yes,
I am always intrigued by this intradural disc. Like I do, in my last 10 years of practice, I unfortunately have never encountered one intradural disc. So, Miss, I just wonder, like, how do you see it, and how do you suspect them when you see them? Maybe I might have missed some of them, but whenever I taken a patient, I kind of removed sufficient disc which was seen on the MRI. So do you see it on the MRI itself, that intradural disc, and then you go in with the plan that I'm going to remove the intradural disc, or this is an intraoperative surprise?
Yeah. So thank you for the question. So we reported 6 cases of intradural disc. I think we have the highest series in the world, and none of them we could diagnose preoperatively. So that is a fact. Everything we wrote in that article was post-operatively. Once we went through the imaging, and we would like to, we tried to give some evidence when you should suspect it. If you want, you can go through. They have given some evidence when is the time you suspect it. But remember 2 things. They are most common at L4-5 level, okay? And then they are most common with Cordai-Koiner syndrome. In the case which I showed you, it was a patient of L4-5 because at L4-5, the disc, the annulus, and the dura are very close to each other. They're almost like a single layer. So sometimes the disc, when the disc prolapses, it straight away goes from, not only the annulus goes out, gives way, but even the dura gives way and becomes an intradural disc. So normally in this case, when we went like a regular case, we went, this is a big disc and you need to remove it. I could not find a disc. So there is such a big disc in MRI, and there is no disc to be found which was which was good enough for me. And that is the time I converted a tubular to a open disc, open surgery, could not find a disc. Then I simply palpated the dura, and I could feel something is there inside the dura. That is the time I did a durectomy, and could, if you see the image in that, and you can read the paper, there's a whole paper to read.
So
We could remove
one of your case where you have not able to find the disc, or most of our cases.
All the cases.
All the cases you are not able to see the disc in extradural space. Then you have to open the dura. What you recommend?
Exactly. All the cases were not that we knew it's an intradural disc. Everything was after we felt there's something wrong. There's a mismatch, and the best way I can tell you, simply palpate. You can feel the disc inside. That is my take after 6 cases which we have done. And whatever MRI finding, everything was retrospectively we have given few, and there is some literature which says these are the signs you can suspect intradural disc. But to be very fair to our audience and to all of you, none of them we could diagnose preoperatively. Not a single one.
So do you make a dorsal durotomy? You go in, you remove the disc, you suture that dorsal back.
Yeah,
and
exactly.
there might be an anterior tear also in the dura.
Yeah. So one of the cases from Indian Spinal, we have combined it. It is Dr. Vikas Tandon's case, where there was an interior rent also. Okay, so then that was sort of patched up. Nothing much to do.
Rent had to be there, correct? Otherwise,
yeah. But normally the rent doesn't cause a problem. If there is a big rent, you need to cover with some glue seal or something. So one of the case, there was a big anterior rent which has to be covered, and we had to do a TILF in that case. But that is not my case. That is from Indian Spinal Injury Center. I took one or two of their cases, and 4 were ours, total 6 cases. But this is the biggest series which I know of today in literature.
Yes, sir, Dr. Suresh.
Yeah, I had 3 cases of one is 2 intradural discs which were diagnosed before with MRI, and I did the durotomy and took out the disc. And another case, there was the MRI reported there is a S1 root schwannoma. But when I opened the longitudinally opened the root, it was a disc, intra-radicular disc, and I have published that also. There is an intraradicular disc. That disc in the intradural space can migrate through the root and present as a or mimic as a tumor. So it was intraradicular disc. And the other two cases were intradural disc, which were diagnosed before with MRI.
Okay. Just Ayush or Suresh, both of you can answer. Is there any cases where there was extradural as well as the intradural component? So sometimes you might try, you find the disc, you might try to pull it out, and there might be leak.
In some of the cases, I had the opportunity to see the disc was forming a pseudo pocket around the dura and causing, even though it was reported as intradural, but there was no CSF leak when I took out the disc. But in one case, it was partly mostly going into the intradural space, and part of it was remaining outside. It was migrating.
So what you did that you pulled the disc out?
I opened the dura, removed the disc, and repaired.
Okay.
The best way is to open the dura. That makes it very safe, so that you can do because they could be like any disc. They could be the case I showed you. It had 3 big fragments, massive fragments. So even if like any disc fragment, you remove one and there is another one, you could have 2 or 3 fragments sometimes. So it's better to do a durectomy in these cases.
Okay, great. So yeah, so let's move on to our next important topic. So today, right now, we have an important discussion on microdisectomy, which is a gold standard. Dr. Amit will be presenting that, and versus endoscopic disectomy, and Dr. Sukumar will be presenting that.
Dhiraj, I think there was a request from Dr. Sukumar that he wanted to present first.
You want to present first?
You want to confirm with him? After Dr. Sukumar had sent a message on our group, on WhatsApp group, that he was in a meeting and he wanted to present first.
Yeah, can. That's fine.
Hello. Hello.
Hello, Dr. Sukumar. We can hear you, please.
Yeah, good evening. Can you hear me?
Yes.
So just I'm sharing my screen. Can you see my screen?
Can.
Yeah. So good evening. Thanks to IOA West Zone and Dr. Sonawane for this opportunity. So here, being all big surgeons here, so the debate would be next 10 minutes. I'll just go through few slides where we try to understand whether endoscopy is going to be the gold standard. Can it be the gold standard in future? So that is the discussion point here. I thank. So thanks to all the teachers who have done excellent work in this field of endoscopic spine surgery. So a traditional surgery for any discectomy or disc pathology is, as everyone knows, that when we use microscope, we need to do a small laminotomy and facetotomy, and sometimes bilateral or removal of lamina is necessary. Minimal invasive surgeries has definitely come a big way, where we have avoided big incisions, lessened the trauma of the muscle injury has been reduced as much as possible. Still, there are some problems, and whatever the purpose of surgery around this disc surgery or spine surgery is to decompress the neural elements to relieve pain. So when we take the options available now, the use a microdisectomy tube or assisted endoscopic discectomy, still there are some problems. What are the problems we face today when we are doing a microdiscectomy or a micro surgical procedure on spine? Still we have a tissue trauma significantly, which we agree that we need to burn some tissue, muscle has to be removed or has to be coagulated. There is a bloody field which sometimes is too much. We cannot identify the structures well, and we work under 0 degree when we are using a microscope, and magnification is to some extent beyond that. It is difficult, and reach obviously to see the crevices, like say you want to see superior, inferior, or to the opposite side. The muscle come in the way, the bone come in our way. So most of the time we end up in removing more bone and try to make a bigger incisions to reach the crevices. And mobility, definitely, yes, even if you are using a tube, sometimes mobility and maneuverability is a challenge in our current practice. So can we overcome these challenges? Yes, definitely. To some extent, endoscopy can address these challenges. Either we can do an interlaminar approach, which is a conventional interlaminar procedure as we do with microscope, or a transforaminal surgery where we come through the foramen of Camden, triangle of Camden through the foramen to reach the disc pathology. So what is the concept here of full endoscopy? It's a percutaneous technique where we need not injure the muscle, cut the muscle. It's a single port technique where it's a wet endoscopy. Always tell the wet endoscopy is because we are using a saline irrigation, which gives excellent visibility, and the magnification is such that the endoscope can be taken to the pathology as near as possible. This gives us a significant visibility, and the use of angles that helps us to reach the places which as a 0-degree microscope cannot reach. And biggest advantage is that sometimes you can do under local anesthesia, and of all techniques available today, it's the least invasive technique. So the gadgets we use are the radio frequency, high frequency, the scopes of various sizes with a single channel, working channel, and irrigation port and light source in all in one tube, and the RF and the micro drill, which are just modified for the endoscope. And it looks like this, where everything is attached to one tube, irrigation, light source, and the camera. So it's the same like a nephroscope uses the urologist uses for the PCNL to remove the stones. So there are two common techniques we do, either transforaminal or interlaminar. Then we go through the challenges. Scar, yes, definitely it is a challenge today, even for when we use for a even a microdisectomy, patients do come to us with the radiculopathy is gone, still they have some back pain, the scar pain still haunts them. If most of my colleagues here might agree with me that even with a good tube surgery, patient complains of lot of back pain initial few days to the operating site pain. So it might be because of the muscle injury or the small hematoma there, still they continues to have back pain. And the mobility, as I said, the endoscope gives a very good mobility to reach to the opposite side very easily without further damaging the bone or the muscle. And superiorly, inferiorly, you can reach from pedicle to pedicle without sacrificing much of the bone. So this is what I was telling about. We want to plan for a pathology around the disc, superiorly, inferiorly. The mobility is very good in endoscopy. So you can see this, just I'm moving it. So with a single port entry, we can have a good superior, inferior, medial, lateral mobility. So this is the X-ray image of a Shyam image, where with a single entry on the ipsilateral side, we can reach to the opposite side inferior, opposite side superior, and ipsilateral superior inferiorly without any much problem. So again, the drilling, you can see here, I'm drilling on the opposite side, opposite extra ligamentous drilling in the stenosis case. So it is very easy to and safe to drill on the opposite side because of the visibility and the angle. And see the clarity of the image clarity and the field is so clear because of the the irrigation here. We can have a crystal clear field. You can see the fine details of the edge of the root, edge of the thecal sac, and the pathology on the root, around the root is clearly visible, so that nothing is left behind. Sometimes happens with when a field is so bloody, we might miss some fragment. That is not the case. Most of the time we can remove the pathology and avoiding the neural injury because of the clarity of the field. And as I said, when compare the microscope and the angle scopes, definitely the field of vision is very good. Field of vision is increased when you compare a microscope with the endoscope. Because of the angle, the field of vision definitely is better. And obese patients, most of the time we deal with such patients, then again microscope becomes cumbersome when we are just using a a non-tubular microsurgery, then again it becomes a cumbersome operating on obese patients. So such patients, definitely endoscopy is a good tool. So this is what interlaminar and transforaminal can do. This is just a cadaveric demonstration where interlaminar. So interlaminar is more invasive, transforaminal is less invasive, because in interlaminar still you need to do some laminotomy and facetotomy in most of the cases in non-L5S1 cases. Again, spectrum, definitely lumbar, cervical, thoracic, every spine surgery today can be done with endoscopy without any, with the current tools available. We can operate most of the pathologies around. And just I'll go through few examples so that the discussion where whether this adds to our microscopy or it's a complementary to microscopy or it might become a gold standard. We just go through the few of the indications which I have done in the past 10 years. Just go through some examples so that I might convince you to that maybe this might be the gold standard. So there are so many indications where day-to-day practice we see most of the patients can be dealt today with endoscopy. So first we'll go just through the transforaminal lumbar. So the positioning same as we do in any other position. This is sorry for the rapid video here because of the time. So this patient is under epidural. So take an epilateral guide wire, needle goes in, the guide wire goes in, the dilator goes in, and we just confirm and just tap it inside little bit. Once we are there, then we put a sheath, and the sheath is inside. Then we are most of the time, if you calculate correctly, and where is as Ayush Sharma was telling, reading MRI is very important. Once you read the MRI, you can definitely reach there. So it's a small posterolateral disc. Here again, you landed. The needle lands in the posterior 1/3 of the annulus near the pathology, and when you are landed there, so it looks like this 12 o'clock being dorsal, 6 o'clock being ventral, and cranial caudal here. So you can see the disc is so much inflamed at the 12 o'clock, and you can see at the 12 o'clock, you can see the fibers of annulus, torn fibers of annulus, and the PLL. I'm just cutting those fibers which are already damaged, and you can see the epidural fat there. And once you start dissecting there, you remove the acute fragment. You can see acute fragment is coming out. See the clarity of the field. So each structure can be seen very nicely without any too much bloody field there. So you can see that dorsally there is still some fragment. I removed the fragment. That is a tear in the PLL, and you can keep removing these fragments until you see the thecal sac. So that will be the end of your removal of the completion of surgery. Now still there, I am not happy there. Now you can see the thecal sac pulsating well. So here, because there was some lateral recess stenosis, I clear these are the two vessels which always accompany the root. I'll just remove them because we need to do a lateral recess decompression. You can remove the soft tissue around the now. Now you can see the now entirely very clear now seen decompressed ventrally and laterally, and the entire disc has been removed. So immediate post-op, you can see there is a small defect there, which is very small when compared to microdisectomy, and you have not done too much of damage there and removed all the fragments which are necessary. And patient goes home with a small stitch and the same day. Again, a huge inferior migrated definitely can be tackled easily with again a transforaminal surgery. Landing is same depending upon the superior or inferior. You can just change the trajectories, and this is a post-op. Immediately the entire fragment has been removed, and this is a dental surgeon was discharged in the same day. Foraminal, extraforaminal, again, this is a area where MRI reading is very important. If you miss this MRI finding, patient falls into wrong hands, will be evaluated and wrongly treated. So this is a very gratifying surgery. Of all disc surgeries in the spine, foraminal, extraforaminal surgeries are very gratifying because patient gets relief immediately, because ganglion is the culprit here causing symptoms. So the moment you decompress the ganglion, the patient is very happy here. So such cases, transforaminal endoscopy is the gold standard because even we use a tube or microsurgery, still we need to do a lot of muscle work there. So here we land in the foraminal, extraforaminal area, clean. So this is, so here we land little bit more oblique, more ventral. So again, you landed here. So the cranial is at 9 o'clock because being a left side. You can see 12 o'clock is the fibers, the capsule fibers and some annular fibers which we cut. So the axilla is towards, that is a traversing route and exiting route is towards the cranial side. You can see there's a fragment, big fragment. I am removing it. So it is between the exiting and traversing route. Here the fragment is just below the exiting route. So there will be some epidural bleed here, and I just coagulate that. You should not be happy once you remove a fragment. You always try to check. You can see this interannular fragment is there. So between the annular fibers, there's a. So this anatomy can be only appreciated in endoscopy. We can't appreciate this in other techniques because of the irrigation here. The clarity is such that we can identify the anatomical details very nicely. So I'm removing all the fragments here. Now you can see the annulus has become lax, and there is extra annular part which is just below. Now you can see the nerve started falling once I remove all the fragments. So once I remove the fragments, you can see the pulsating route, that is the traversing route is nicely seen. That's the traversing route, and all fragments has been removed below the root. So this is a post-op. This is one more case where pre and post, you can see the entire fragment has been removed. And this is a second case where the root is seen, and just below that you can see the fragment here. So foraminal stenosis, again, isolated foraminal stenosis is very common in patients, especially in elderly, where they come with isolated radicular symptoms without any back pain. Such patients, this endoscope is a wonderful technique where you do a foraminoplasty and just remove the part of superior articular facet and widen the foramen. They will be the very most happiest people. You can see here the pre-op, the left side and the right side post-op, where entire the foramen has been widened. So patient can see pre-op, post-op. And upper lumbar disc definitely is a big challenge when we open, when we do with the microsurgery, where we need to do a lot of lamina and facet removal to reduce the traction or retraction on the neural elements because the thecal elements are more bulky because of the conus cauda. So this upper lumbar, definitely the transforaminal endoscopy is superior. When you can see here, I have removed, and the hard elements also has been removed. Fecal sac is well pulsating. This is a young lady, 26-year lady I had operated, and you can see I had operated her in 2018, immediate post-op, just a shell seen there. And now you can see the latest MRI shows complete modification of the annulus there, as if no surgery was done. So that is a precision and results of this transforaminal surgery if done correctly. And annular ulcer, what we call is a common term which you might have seen commonly. It's called high intensity zones are there, which are chronic non-healing areas, sometimes trouble the patient. This is a marathon runner, full marathon runner. He had a significant back pain. He's a nephrologist by profession. So he was almost crippled, and his passion of marathon had stopped. So we tried, I tried transforaminal surgery, debrided the whole area. There were a lot of neovascularization in that area. Lot of granulation was there. I just debrided this. I operated him in 2015, and this 2019, you can see the entire high intensity zone is gone. And the disc started rehydrating. You can see the previous scan, the disc was dark. Now you can see the disc started rehydrating, and it has healed well. So definitely there is a role of endoscopy in such cases. And adjacent level disease, again, it's a big menace when we start doing more and more fusions. Adjacent disc disease in this elderly lady who doesn't want one more fusion surgery or one more redo big surgery. So such patients will come with just a radicular symptoms. So we can offer them just a decent transforaminal surgery where we can decompress the neural elements, remove the disc fragment, and the thecal sac and root is well decompressed here. Discitis, again, it's a very big problem for any surgeon. It's a nightmare. Any one of his post-op patients or de novo discitis is difficult to treat. And such cases, selective cases, we can offer them transforaminal decompression, lavage, and antibiotics. Most of the time, patient becomes better. In this patient, this was a microdisectomy done elsewhere. He came with a lot of back pain, and you can see I put a needle, and there's a lot of material, purulent material coming out through the needle. And once it was taken and it was debrided, debridement has been done and antibiotics given. So he recovered very well. So we avoided one more big surgeries. And fusion, again, definitely this endoscopy works very well, where we can do good fusion without doing a big openings, and avoid facet, too much facet removal also. So this endoscopic fusion is going to get modified in a big way. So modify and it is the future. So, and coming to interlaminar, again the same concept. Interlaminar, I'll just skip this for the lack of time. And again, huge migrated discs like this can be operated with a single small port, drilling small laminotomy above below. I've done removed the entire fragment here, and you can see this entire thecal sac is decompressed. So the disc is removed. So 2 level, it is almost coming from L4-5 till S1. So it has been, that's a space, and it has been entirely removed. That's a body of L5, and you can see it's going down L5-S1 space. So entire disc fragment has been removed, and patient, you can see this lady came like this and goes home with the straight back on the next day. Stenosis, again, definitely it helps better. It's a very good tool for stenosis. I'll just rush through this. Post-op, you can see we have not violated too much of bone here, just address the pathology. Facet cyst, again, endoscopy is going to become a gold standard. So you can see elderly patient with a severe radicular symptoms. Just remove the entire cyst and decompress the neural element. So entire neural elements are decompressed. So you can see the excellent post-op, immediate post-op. Then, so dorsal, again, this patient D8, D9 disc. So it can be done. D12, D11, L1 disc can be done very easily with transforaminal surgery. So post-op, again, interlaminar dorsal, the ossified OL, yes, it's going to change the scenario now. You can see the entire OL has been removed, interlaminar approach, and you can see post-op, entire OL has been removed with a small opening. Cervical, again, selected cases, acute foraminal, definitely is a big a boon with endoscopy. So it's a small disc fragment. You can see the thecal sac root. Entire fragment is put in one go. You can see the small fragment. So it's a small cervical laminoforaminotomy has been done. So definitely there are limitations. The learning curve is a big aspect where you need to have a steep learning curve. So definitely training will help it. And cost of initial setup is a big headache for full endoscopy. But Indian instruments are coming up, so it should help us. And definitely future is there for full endoscopy. And I am not telling that it is replacing microsurgery, but yes, definitely it adds or it is complementary, and in future, definitely it is going to be a gold standard. That's what I believe. And thank you.
Thank you, Dr. Sukumar. That was an extensive.
Sorry for I took a little bit longer time.
Yeah, that's
just
fine.
to convince the friends that
too much forward. So over to Dr. Amit. So Dr. Amit will be for a microdisectomy, which is a gold standard at present? Yeah.
Thank you, Neeraj.
I'll just.
Are you able? Please unshare your screen, Dr. Sukumar.
Yeah, I'm doing that.
So I'm very thankful to the organizers because they gave me the easier talk, and Dr. Sukumar himself was quite confident that it is not yet the time for the endoscopy to take over the microdiscectomy. So microdiscectomy still remains the gold standard. And why it is so? Because whenever we are doing a surgery, the aims of the surgery are, especially for a decompression spine surgery, that there should be a thorough decompression. If required, the surgery should have extensibility, that if you need to go level up or down, or you need to go to the opposite side, you need to be able to achieve that. You don't only do the job for the time being. I had so many. This morning I saw a patient who had her microdiscectomy done about a year ago. She was having right side leg pain. Now she's having left side leg pain. So there are some situations where we need to do a prophylactic job also, not only take care of the current situation, but try to take care of the forthcoming scenario as well. If there are some complications like dural tear, you should be able to deal with them then and there only. If for any reason you need to convert the procedure to an open procedure, you should be able to do that easily. And the technique should be easily available, and there should be a good cost benefit ratio. So when it comes to decompression, I have never had a problem with the microdiscectomy procedure. As you can see that we get enough exposure when we are doing a microdiscectomy, whether we are using a macula retractor or we are using a tube. After endoscopic discectomy, my colleagues like Dr. Sukumar are always in doubt, and they keep on showing this removed piece of the disc to convince themselves and to others that, okay, yes, we have removed enough. And they keep on doing the MRIs. So I got this from one of my friend, endoscopic spinal stenosis treatment. And then he is not convinced. And then to me, the pictures almost look same, pre and post. And then he is trying to convince himself that could this be because of gel foam and glue. So I just put these picture for the current context. And look at my friend's own LinkedIn post, Dr. Sukumar Suraj. So he had put this post-op MRI, and immediate post-op and 1 year post-op, and people are asking him why he is doing MRIs right, left, and center. And unfortunately, Dr. Sukumar never had the last word. Similarly, another patient who he did an MRI, and then somebody commented that as long as the patient is happy, why we need to worry about it, whether it was a microdiscectomy or it was an endoscopic discectomy. So anyway, coming to the extensibility, you do a tube microdiscectomy. The tube is that L4-5 through the same incision. You can just tilt it to the L3-4 also if required, and go to the L5-S1 also. So yes, incision remains same, and you can still achieve 2-3 levels because of the lordotic posture of the lumbar spine. Going to the over the top is well-known phenomena using the tube, and people have done extensive research on this. You can burr out the base of the spinal process, and Dr. Sukumar also showed that he can do it with the help of the endoscope also. But if you need to go to the next level, then another incision, another 1 hour at least. Time required for initial learning curve. Every procedure has its learning curve, and there's nothing wrong with that. But if there is a learning curve is so steep, do we need to climb every learning curve and subject ourselves to this ongoing torture? So no, not necessarily. If we already have a procedure which is well proven in the literature, then just because we got a new toy, we don't have to jump for it. Time required for surgery, and otherwise if you go for every learning curve, then you might have to face these kind of disasters. And these happens whenever you are starting a new procedure, we all know. These kind of setups require long time in the OT, and like half an hour, 45 minutes are gone just to set up the OT. And in our kind of scenario where OTs are charged on hourly basis, we have to be very, very careful. Cost involved. Dr. Sukumar himself in the last slide accepted that there is a lot of cost involved. If you want a full setup of endoscopic equipment, you need at least 50 to 75 lakhs, unless you want to just do a half-hearted job or just have some equipment. So not only the endoscopic equipment, which range from endoscope, which are of various kind. You need to get an interlaminar, you need to get a transforaminal, you need to get stenosis scope. There are separate scope for cervical spine, though you can mix and match them and you can use one scope for other procedures also. But ideally, if you really want to have the full armamentarium, then you need all these scopes. You need to have burr machine, you need to have radio frequency ablation, you need to have laser machine also, in fact, to dissect out the bone. Video trolley camera luckily are available in most of the orthopedic hospitals, but again, if you are going to run a spine hospital only, then you need to invest into these also, and not only the cost initial, maintenance also later on, and ultimately the cost will have to be borne by the patient, so the bills are going to be high. In contrast, we are able to just work with the 5,000 rupees microdisectomy Makala retractor, or if you are a little more fancy, then you can use these kind of tubes. Microscope, if your hospital has good, otherwise these headlights and loops work well, and literature has shown no difference whether you are using a microscope or headlight and loop in terms of the initial outcome or the later on outcome. So endoscopic advantage, initially I was going to give this talk and I was assuming that Dr. Sukumar is going to speak later, and then I wanted to cut his points in advance only. But I got lucky and he spoke before me. So let's have a look at his point. Small incision. So how small we want to be, and does it really matter to the patient? Like, is it really significantly different whether the patient has 1 centimeter long incision or a 2 centimeter long incision? I don't think so. The recovery pattern remains same. What Dr. Sukumar was pointed out that after the microdiscectomy procedure, a lot of patients have back pain, but that back pain he was blaming on the muscle dissection and the hematoma. Not necessarily. It could be just the procedure pain, or it could be the original disc degeneration pain. So incision, I am not too convinced. Local anesthesia, yes, the transforaminal discectomy you can do under the local anesthesia, especially for somebody who is unfit and not ready for any kind of regional or general anesthesia. But what I've seen that most of these transforaminal procedures are done where we would not have done the surgery only in the beginning, like why Dr. Sukumar showed that high intensity zone. I probably would have never done surgery on that patient, maybe at most given a steroid injection. Interlaminar again has to be done under general or regional anesthesia, which I think we are also doing microdiscectomy under regional anesthesia quite frequently. Early discharge, how early we want to be, what's the rush, like patients have come for the surgery, let him be here in the hospital for a few more hours. We have discharged the patient on the same day after microdiscectomy surgery, but what's the rush? Patient can go home next day also. They have come for a big surgery, they have come for spine surgery, they were so much suffering, so they can have at least 1 night of stay in the hospital. Now for the people who believe in literature, so looking at the literature, there are the best I could find in the literature that endoscopic discectomy is trying to come closer to the microdiscectomy. It is definitely not superior as of now in today's date, but it's coming closer. But at the same time, look at the main thing which Dr. Sukumar had pointed out, that lesser hospitals. So how much lesser? 15 hours versus 7 hours. I mean, come on, that is not what we are looking at. We are looking at something which is long term. So that is not convincing to me. Is endoscopic discectomy going to be the next gold standard? As of now, I don't see that happening in the near future. At most, it might be non-inferior, but looking at the other thing, the inability to do a prophylactic job, inability to do it at everywhere, a lot of cost involvement, extra setup requirement, extra time involvement. So it is definitely there is a lot of demand in other aspects, even if the procedure itself is able to give us the similar results. So no literature has shown it superior to the microdiscectomy. They are just, as of now, they are just trying to convince to us that it is not inferior to the microdiscectomy. So that is the current situation of endoscopic discectomy, but all the problems I told you earlier associated with the endoscopic discectomy. Thank you very much to Dr. Sukumar for taking his talk earlier, so my talk became a little easy. Thank you very much.
Actually, Dr. Amit presented it as a debate properly, and the way he presented, though Sukumar has taken good time and given a very good perspective about endoscopy, Dr. Amit made it present like a debate. And Sukumar, you want to defend or add something after this?
So what Dr. Amit said, so I agree with, current day, discectomy, just for discectomy, definitely when you look after 1 year, there is no debate that most of the open discectomy, microdiscectomy, and endoscopic discectomy, the results are same. There is no debate about that. The advantage of endoscopy comes when you want to do a little bit extra. So most of the studies, they have studied for only a disc prolapse. They have not studied for inferior migrated versus open versus micro versus endoscopy. No, it has not been done like that. It is only for the disc prolapse as a whole. But when you take extra, like say the difficult cases where migrated disc, lateral recess stenosis, bilateral stenosis, global stenosis, definitely endoscopy is going to change the scenario. But it is early where only we do good studies, randomized control studies, and publish the results. Only then the debate would be more meaningful, rather than me telling that out of my experience, my results are good. That is not a correct term to tell today. So definitely I agree with Amit that maybe 5 years later he will agree with me that this is going to be a gold standard.
I
Thank
happen
you.
to have.
Amit, also I want to say one thing. That was too much for you to go and search his LinkedIn and.
No. We are in constant. I was
research from his side.
And I recently saw his post. This is not a very old post. This is, I think, a week or 10 days old post. So I took advantage of the situation and inserted it. So I happen to have a transforaminal scope. I put it in the patient 5 times. But like as I told you, was not very convinced, and I was very happy with microdisectomy, the way things are going. So then I had to kind of and then as I told you, it requires just the scope I got is cost me a fortune. If I wanted to go for a burr machine and the radio frequency and laser machine and different kind of scopes, it's a big investment. And then still you cannot do it everywhere, like for somebody like me who is working at operating at 5 different places, it's a difficult thing to do.
Right. Thank you.
Thank you.
Just because of constraint of time, we have to move to our next talk. Dr. Hitesh Modi, he is a senior spine surgeon in Gujarat, a known figure. So he'll be presenting on recurrent disc and his protocol on that. Yes, Dr. Hitesh.
Thank you very much. Good evening to everyone and wishing you a happy new year. I am Dr. Hitesh Modi and going to talk about the recurrent disc herniation, what, when, and how to deal. I do not have any disclosures. As we know that the recurrent disc herniation is although a very common in routine clinical practice, it is very interesting to know that the literature is scarcely published on this matter. Literature says that recurrence is found in 5 to 15% of cases, or at somewhere it is written 1 to 21% who were operated for PID. Recurrence after the surgery for recurrence can go up to 27%. And incidences of recurrence is high in annular tear, or we can call it as broad-based disc, as compared to the extruded disc. This interesting article says that there is no factor like age, sex, trauma, prior surgery, level of PID, type of surgery, duration of symptoms, etc. are associated as with the predictive factors for prognosis in recurrent disc herniation. The famous article by Kareji et al. Have published their famous prospective study to evaluate the recurrence based on 4 types and shapes of disc herniation, like fragmented fissure, fragmented defect, fragmented content, and absence of fragmented content disc herniations. First 2 are basically narrow based and later 2 are broad based disc herniation. And based on that, they have said that the small defect discs are associated with lower recurrence, while broad based disc is associated with higher recurrence rate, which is basically a baseline study behind studying the recurrence of the disc herniation and its treatment. Another important systematic review suggested that there is no guideline to assist surgeons in deciding which approach to be taken to treat recurrent disc herniation, as there are no comparative studies available. And based on their search, they have found that that the fusion may have a greater improvement in pain compared to the reoperation without fusion. While on the other hand, another article suggested that some patients respond to non-operative treatment and surgery will be required for those who do not respond to conservative treatment or patient present with the neurological deficit. Additionally, repeat discectomy or the fusion surgery both work very well and with similar complication as well as clinical outcome. And therefore, based on the literature search as well as my experience, I feel first we should define the recurrence, which is basically a disc herniation at the same level on the same or opposite side, occurring after a pain-free or medicine-free interval for minimum 3 months in an operated or conservatively treated lumbar disc herniation with positive clinical and radiological features. So therefore, let us take some of the cases. Like this first case is 40-year male who had PID at L4-5 level and conservatively treated very well. However, the disc recurred after 6 months and again treated conservatively as he responded very well with the medicines and steroids. 4 months later, again the disc herniated and recurred, and this time it was third time and patient was operated with discectomy procedure only. Second case, 42-year male presented with acute PID left L4-5 level, which was treated conservatively, and then recurrence happened after 6 months. And this time MRI showed there are some bright signals suggestive of more sort of inflammatory changes than the compression, and therefore patient was treated conservatively. The third case shows 45-year-old male having acute PID at L4-5 level, treated conservatively with nerve root block. And after 1 year, MRI picture shows a significant regression of the disc herniation. However, the disc recurred after 3 years and treated with micro endoscopic or tubular retractor discectomy using only fragmentectomy. We had not done any fusion procedure. The fourth case, 48-year female with PID L4-5 and treated conservatively because she was reluctant for surgery. However, after 4 months, the recurrence was happened along, and patient presented with the cauda equina syndrome, and this time the fusion procedure was performed. Another case of 28-year-old male who had initial PID at right-sided L4-5 level, treated conservatively with good outcome. A huge up-migrated recurrence happened 4 years later after the initial incidence, and it was now on the left side. Since there was no instability in spite of mild retrolisthesis and no degenerative changes in end plates, he was treated only with microendoscopic discectomy. The 35-year-old male who is auto driver and who was treated for MED for a broad-based disc, and after 5 months of initial surgery, he presented with again the similar symptoms of right-sided radicular pain with small recurrent disc, along with significant symptoms of back pain, which was not treated with conservative treatment, and therefore he was operated for T-lift procedure. And the last case, which was actually in fact a lesson for us, for me, that 52-year-old male who had discectomy prior 5 years back and now presented with severe radicular pain, with MRI showed a small disc at the same side on the left side at L4-5 level, and we because of the severity of the pain, we treated him with microendoscopic discectomy. However, he remained pain-free for only 10 days, and again symptoms recurred with again a larger disc herniation, and ultimately patient landed to some other doctor and got relief for the relief. So based on my experience and literature search, I feel that the algorithm which might be helpful, and I feel that recurrent disc herniation first should be treated conservatively with nerve root injections if disc is small, if bright signals are on MRI, if symptoms gets better with medicines, and there is no significant instability on X-ray. Only discectomy should be considered for fragmented, sequestrated, or migrated disc with predominant lower limb symptoms without significant instability or without degenerative changes on end plates. And fusion should be considered where low back pain is much more significant and instability is present. If there is a broad-based disc herniation and signs of degeneration along with the modic changes on the end plates, or patient presents with poda equina symptoms or severe neurological deficit, or if patient presents for the recurrence of the recurrently operated disc. And in these cases, we can operate for the fusion. Thank you very much.
Thank you, Dr. Hitesh. That was wonderful. So just tell me what you have mentioned on the flowchart that is written by you yourself.
Yeah, I have done, since you have given me the project. So I searched on the literature, I saw all my cases, and then found out that I think this would be the most appropriate algorithm which needs to be followed. Actually, we all follow in our clinical practice, but there is no specific algorithm which I see on literature search.
So you mentioned about modic changes. Why modic changes is the deciding factor for fusion?
Modic changes and end plate degeneration may be similar, and when modic changes or end plate changes are there, patient usually have decreased disc height as well as severe disc degeneration, and those patients might be presented with significant amount of low back pain. And even if in such patients, if you operate for only discectomy procedure, later on or post-operatively, patient may constantly bother you for the complaints of chronic back pain. And that's why I felt that fusion would be a better option in these cases.
Just another question. How is your, just brief, the crux of everything, how is your protocol different for a primary disc than a revision disc at the same place? So usually we tend to go more for a fusion. So how you decide among?
See, more or less what happens that if the patient presents predominantly leg pain, and if the patient is having primary case, we usually tend to give them conservative treatment. And we see if there is a broad-based disc herniation only on one side with significant leg pain, still we tend to operate without fusion in primary cases. But if we find a secondary case or recurrence of the disc herniation with a broad-based disc herniation again, then definitely fusion would be a much better option rather than choosing only surgery without fusion.
Right. Any questions from our panelists? Okay, so we'll consider this as the last talk, and I will give my proceedings to Dr. Ajit Shinde. Thank you very much, sir, for pushing us for this wonderful program. And today's session was learning for all of us, and it has gone excellently well, sir. Over to Professor Ajit Shinde, President of West Zone Orthopedic Association.
Thank you, Dhiraj. Dhiraj, am I audible?
Yes, sir. Yes, sir.
It was a wonderful session. I am glad I could attend it. I apologize in the beginning because of some technical issues. I was not audible and I could not join. But I must say, all the faculty clear the concept and guided very well regarding the management principle of cervical and lumbar disc disease. I would like to congratulate our moderator, Dr. Dhiraj Sonawane, Dr. Shailesh Hadgaonkar, and Dr. Vishal Kundnani for amazing session. And like to thank all the faculties. They were excellent in their presentation. And lastly, I'm thankful to OrthoTV for their nice cooperation. Thank you, everyone.
Thank you, sir. So we will consider this as a conclude remark, and thank you very much for everyone for contributing, and we'll conclude this session. Thank you. Goodbye.
Thank you very much.
Thank you.
Thank you. Thank you.
Okay, sir. Can I end